Let me give you a startling statistics. It was based on a study that was done by the Centers for Disease Control in 2017. And they looked at a large cohort of patients who were given opioid prescriptions. And what they found was that if you give 1 day prescription of opioids to a patient, the risk of that patient continuing to use opioids 1 year, 6 out of 100 patients would continue to use those opioids. If the prescription was given for 10 days, 13 out of 100 patients would be using opioids, would be at risk of using opioids at 1 year after that prescription. And if a prescription was given for a month, a third of those patients, 30 out of 100 patients would be at risk of using opioids 1 year after that prescription. It's important to understand a pain profile of a patient having a surgical procedure. The period initially begins in the first 48 hours where you have really intense pain after surgery. And after that, the patient transitions to what we would call like a transitional phase, where the pain starts to resolve, the body heals itself, the pain starts to resolve, and gradually the pain scores or the pain experience goes down till there's complete healing and the patient has no pain at all. This transitional phase can last from days to weeks, depending on the kind of surgery that the patient has. Now, in the first 48 hours, we have come up with great methodologies to control that acute intense pain that happens in the first 24 to 48 hours with our nerve blocks, multimodal medications. And then in that transitional phase, these nerve blocks, they usually last for about 24 to 48 hours, sometimes for maybe up to 3 days. But when the patient is in that transitional phase and they are usually at home, then the medications, including opioids, become the bedrock of management of that pain. It is very critical that we control the pain in that early phase as well as in that transitional phase while the patients are usually home and recovering. The strategy of multimodal strategy is also nerve blocks forms a part of that strategy. And the nerve blocks, they are really, really powerful way of controlling pain because it essentially blocks the transmission of pain impulses from the periphery to the brain. So once the nerve block is performed, anything distal to the nerve block or anything at the surgical site completely feels numb. About 3 years ago, I co-founded a company called Gate Science, and we created a product called Relay. Now, this Relay device is a device that you can place right next to a nerve, a target nerve, depending on the location of the surgery. And this Relay device allows you to inject a Novocaine through that device to create that nerve block, which really works in that first 24 to 48 hours after surgery and blocks that intense pain. Once that nerve block wears off, the Relay device has an integrated pulse generator that can transmit tiny pulses of electricity to the target nerve and neuromodulate that nerve and continue to block the transmission of those pain sensations at the peripheral, at the location of the nerve, as well as in the spinal cord, thereby prolonging the duration of the pain control. And this Relay device, can be left in place for up to 28 days, so it has the ability to be able to control the entire episode of post-surgical pain, not only the early intense pain in the first 24 to 48 hours, but also the transitional pain that occurs for days or weeks after surgery. The Relay device is actually, if you think of it from a conceptual point of view, it is a device that uses nerve blocks as well as neuromodulation, two technologies or two techniques that have proven to control pain. They both have their limitations, but combining the two into a single platform is really sort of the opportunity to be able to fill that analgesic gap that exists in that transitional period. The device is controlled by an app on your phone. And so when they go home, they have an app that they can use the device or titrate the amount of electrical pulses or the strength of the electrical stimuli to be able to control their pain or match the intensity of the electrical current to the level of pain that they're having. So the patient feels in control while they are at home, recovering at home. So that's one thing. The second thing is because we have an app now, which we call the Gatekeeper app, it creates a digital platform to be able to communicate with these patients while they are recovering at home. We want to inherently do good to our patients and to try to develop strategies, techniques, medications that empower us to reduce the use of opioids and deliver the same level or even better level of care. And so there's this inquisitiveness, there's this inventiveness that drives us and is an incentive for us to do better. Our experts in reimbursement and outcomes, they should sort of focus in on these latest technologies and medications and incentivize them to be used in patients, because downstream they do make a difference in the opioid crisis, in the chronic opioid use, and patients' experience of postoperative outcomes. And I think education of these in these forums is essential. I would encourage the audience to become more aware of the opioid crisis, but also when they are having procedures, to talk to their anesthesiologist or their clinicians about using opioid sparing medications, devices, and it's everybody has to sort of join in to be able to reduce this opioid burden and this opioid crisis.
I've been in practice almost 25 years, and we've certainly seen a swing in the healthcare system around pain and pain control. This notion that we're going to have to tough it out is not appropriate. Our patients deserve appropriate pain control. If left untreated, acute pain can become chronic pain, and that has lasting implications beyond just the pain episode. But this notion that there is absolutely zero pain at all ever after a surgical procedure is also probably a bit far-fetched. And so there's a happy medium in there where patients are comfortable and accepting of where they are in their pain level, but yet are able to still function and work and get around and rehabilitate. I think the good news is now we're seeing availability of other options, both in the acute care space and in anesthesia in particular, with the advent of various regional anesthesia blocks, which means it's, to explain it to a patient, we tell them, well, we inject medication to help numb up part of the body where we're working, and hopefully that lasts a little while to help you with that immediate acute pain postoperatively. But also non-opioid alternatives, enhanced recovery after surgery, or ERAS, is a big piece of what we're all incorporating into our practice, which is really a interdisciplinary, multifaceted approach to pain management that begins to remove opioids as the foundation for pain control. I think one piece that we sometimes either overlook or don't recognize as much is the psychosocial impacts that long-term chronic pain has on patients. I've seen examples, unfortunately, of patients who've ruined family relationships over poorly controlled or uncontrolled pain. And so it does go beyond, we just need to get the pain controlled, but there's really a continuum there of pretty tragic outcomes that can happen in patients that don't get good chronic long-term pain control. A lot of this is talking to patients preoperatively and setting ground rules and our kind of the groundwork of what are the expectations. I expect you to be reasonably comfortable, but you're probably not going to be absolutely, totally 100% pain-free in this next, day or two. But we're going to get you to where you can get up and you can move around and you can do things that we need you to do to help recover from your surgery. There are a large number of newer medications that are good at controlling pain. We call that multimodal analgesia. So we use a little bit of several different medications that all treat the pain pathway in different places before we even start the pain process, maybe even before we start surgery. Sanjay certainly described an incredibly novel approach, and certainly from a science perspective, it really makes a lot of sense that we would have the opportunity to both numb up acutely and then have some degree that piece in the middle really is the part that's very, very difficult. That I got you through the first day or so after your surgery, but the next week or two, it's going to be kind of rough because up until now, there's really not been a ton of good options there. We also know that interdisciplinary team, when it's surgeon technique all the way through long-term rehabilitation, all of that is changing to really put the patient front and center on understanding the expectations of what should I be feeling, what is normal to be feeling at this point in my recovery process. The lack of control that you get as a patient in the healthcare system is pretty profound. And you really do have this sense of vulnerability, or gosh, I just hope everything goes well, but I really have no control as a patient, as an individual over, for example, my pain control, my pain management. And the idea of empowering the patient from a control perspective, there've been multiple studies that show that if a patient, an individual, feels like they have some sense or some degree of control, that their perceptions of pain and their pain scores are less. For the practicing clinician and those of us that have been out in practice, it really is incumbent upon us as individuals and our professional societies and healthcare as a whole to ensure that we all remain both up to speed on current data and techniques, but then also potentially some retraining around in the case of Sanjay's device when it comes to market. I look forward to learning how to implement that in my practice. Our patients are demanding this. The educated, informed patient is asking me in my practice preoperatively, am I going to get fentanyl, for example? And they're calling it out by name. It's a very powerful opioid. It is something that we've used in the anesthesia space for quite some time. But with all of the illicit use of fentanyl and unfortunately, just terrible epidemic of contaminated fentanyl, I'm having patients ask me, please don't give me that medication. I know a friend, I have a colleague, somebody at my school, in the case of the teenage patient, for example, they died because of an overdose of that, and I don't want that to happen to me. And that's great to hear that we have an informed group of patients out there that are coming to us and saying, help me understand what are my options. I'd like our audience to realize and recognize that the clinicians and patients really want to have the best outcome possible, and that if policy interferes with that or gets in the way, it is not only potentially dangerous at worst case scenario, but it is really disheartening to not be able to offer a patient what may be the most appropriate technique, device, drug, whatever that may be for that episode of care. Changing policy and regulatory barriers, removing those regulatory barriers to allow good pain control to happen is absolutely critical.